Thanks so much for that wonderful introduction, Dr. Lennon. I'm excited to be with all of you today. This is my favorite topic to talk about, health equity and the journey that we've been on at Atrium Health. This is truly the work that I think has united a lot of inspiration among our teammates and our leaders and really our community. And we feel like even though we've done a lot over the last few years, there's a lot more work to do. And so I'm planning to walk you through not only what we've done in the past, but how we think that this is going to grow our work in the future. So just to introduce Atrium Health to you, if you're not familiar, our mission is to improve health, elevate hope, and advance healing for all. And that for all part of our mission is incredibly sacred to us. That's really what this entire conversation is about and what's driven a lot of the work that I'm going to share with all of you today. It is infused into our operations and how we think about our work and how we reach out to our community. At the end of the day, we want to be the first and best choice for care for all. So just to remind you of our markets, we've got over 70,000 teammates spread across North Carolina and Georgia, over 40 hospitals, and $2.4 billion in operating revenue. We are a growing healthcare system. We've recently integrated with Wake Forest Baptist Health, so now it's called Atrium Health Wake Forest Baptist, and then Floyd Health in Rome, Georgia. So we're excited about the growth, and we're thinking about that not just in terms of how we grow our impact inside the four walls of our hospitals and clinics, but also how we grow it in our work around health equity and social impact, and how do we start to think about scale and that sort of thing. So that's also what I'll talk to you about today as we move through the conversation. We do have $2.3 billion in community benefit. There is a lot there to talk about, and some of that community benefit work I'll share with you as we work through. And we're very proud of the fact that as a percentage of our operating expense, it occupies a higher proportion of our overall operating expense than most of our peer health systems, and we're very proud of that. So let's talk about the journey. I grew up in the healthcare diversity space, and so this has been a long journey for us, and I'll talk to you about some of the little ways that we've started to build capacity around health equity and how it's gotten bigger and bigger over time, and how we're thinking about it more holistically now than we have ever thought about it in the past. And it's a journey that we're committed to being on forever, and that's why it's baked into our mission. So one of the first things that we did, and this has been a few years ago now, we realized that in order to even start the work of health equity, we really needed to do that foundational work around our data. And there's been a lot of conversations nationally, and I'll share that everything that I'm talking about today, I think any health system can embark on. It doesn't always have to be this massive resource lift, but it does take some dedicated time and focus. And so I'll talk to you about how we started to tackle it, but I think there's varying degrees of scale that you could start to embark upon this work. And because my hope in having this conversation is that other folks will start to go down these journeys as well. We realized that we needed to clean up our data. At the time, 12% of our patients were unknown race or ethnicity. And what I mean by that is, we knew their names, we knew all kinds of health information about them, but when we looked at it in the aggregate, we realized we didn't know what their racial or ethnic group was. And part of that had to do with how we collected the data. There was a lot of inconsistency around how we collected it. And then when we started to dive deep into medical records, we would find all kinds of miscategorizations, right? So we would find that a patient that we clearly knew from, the providers knew was Samoan, but they were categorized as Hispanic. I had a colleague who's African American. One of her children had been coded as white. One of her children had been coded as black. And so she didn't really know how that happened, because that certainly wasn't categories or boxes that she had checked. but someone had checked for her. And that really boiled down to what happens in the registration process. You know, it's oftentimes a required field, and so it's possible that a registration clerk just eyeballed someone or made an assumption about who they were so that they could keep the registration process. But what that was creating was a lot of limitations around, you know, what we were able to know about our patients. And in the aggregate, it was creating limitations around how we were able to analyze and guard against disparities in our care patterns. So we embarked upon a whole initiative. It took us an entire year, soup to nuts. It started with a pretty robust EMR redesign. So it was thinking about new workflows for our registration staff. New codes were introduced in our system. So historically, we had collected those kind of top level Office of Management and Budget race and ethnicity codes. These are the ones that you're all familiar with: Black, white, Asian, American Indian. So those are the general categories that most of our systems kind of roll up to. But we were realizing that we were missing a lot of granularity, and a lot of patients didn't see themselves in those buckets. So we fanned out, blew out our options from about 7 to over 50 now. So we have between the race and ethnicity categories, we collect those categories separately, by the way. We had 40 options now. And we also made language a hard stop. So it was required filled in order for registration to move forward. The reason why that matters is that we were realizing that in clinics where we knew as much as 80% of our patients in that clinic were limited English proficient, we would look at our data and realize, well, our data only shows 30 or 40%. So we didn't really have a full sense of how many of our patients were limited English proficient. And that should also drive resources and care patterns. So we made that a hard stop. We also introduced sexual orientation and gender identity. Some folks know this is the SOGI data category. We introduced that into the history section, and we also provided options for our registration staff to collect gender identity data as part of the registration process. That was really important. We heard a lot of feedback from the transgender community about how important it was to be able to, if they wanted to, be able to provide that information during the registration process. So after all of that EMR design work, we created e-learnings for our registration staff. We engaged in an internal communication strategy and an external communication strategy, which we didn't end up pulling the trigger on, but we had it ready in case our community members started to ask questions. Why are you asking this information? But we did have patient-facing collateral in the hospitals and clinics. And it was really, we asked because we care. We're not the first people to say that, but we put together collateral that was explaining to our patients why we were asking these questions. And we spent a ton of time with the leaders of our registration teammates to make sure that they felt comfortable managing through. We created job tools that actually scripted registrars so that they knew what to say when a patient asked questions or felt uncomfortable with the question, because it was really getting our registration staff comfortable moving away from an eyeballing behavior to now asking the patient, to patient self-identification behavior. And almost overnight, once we flipped this on in January of 2019, almost overnight, we saw our data start to clean itself up. So now we're down to, and I look at this data all the time, we hover around 2% of our patients are unknown race or ethnicity. Some of that's legacy because they haven't been back to us in a while, and we still give the opportunity for patients to decline that question. But I want to stress how important it was in terms of being able to fan out the options for patients to see themselves in the list of options available to them, how that will just naturally clean up your data. And I'll use my husband as an example. He has no idea I'm talking about him right now. My husband's family immigrated from Lebanon, and they can trace their ancestry back to the indigenous Phoenicians of the land that is now called Lebanon. And he's very proud of that. And if you ask him, he is never going to self-identify as white. But the U.S. Census Bureau may project onto him that his ethnic category technically maps up to white into those broad bucket categories. But if forced, he will then decline that option or click other or something like that. And that brings me to my last point. We eliminated the option of other. And that's really important too, because we wanted to get to a place where we were collecting this data all the time on patients and really discouraging use of the other patient decline. So that was a big part of our initial journey, and that led us to have really pristine data. And that data was then mapped into, so we actually, once we collected all those categories, then we had to go through a very meticulous mapping process where we mapped every potential scenario. Patients were now able to collect multi-select on race categories and ethnicities. So we had to map all of the scenarios back to those office of management budget categories so that we could do those analyses that I mentioned earlier to really guard against health inequities in our care patterns. And we mapped it all to what we called our demographic data wall, which is a homegrown health equity analytics platform that allows us to analyze our data by race, ethnicity, and gender, and then be able to drill down by location. And we have all kinds of data. We're always fiddling with this tool and enhancing it. But we have all kinds of data loaded into it. We have inpatient measures, mortality, length of stay. We've got all kinds of pop health metrics, We've got patient experience, core measures, and we also have patient demographics so that at any given time, we know exactly who our patients are. We've loaded in infant mortality, and looking at that data, we've been able to find all kinds of challenges around how we were collecting data on newborn that we needed to address through this process. And so that's been a really great journey to allow us to identify all kinds of care patterns where we want to start to intervene on and develop interventions around. One of those is what we called our colorectal cancer screening health equity goal. This was where CMS, the year that we launched this goal, had issued a report really encouraging health systems to do both that race and gender stratification so that you could understand the nuance of your care patterns and health equity concerns. And what we found is when we did that, actually Hispanic males fell out as significantly lower in screening rates as compared to their white male counterpart. And what you can see here is after we intervened, we did see that gap narrow over time. And it was really a journey. We learned all kinds of things through this process that didn't just benefit Hispanic males, but really benefited all patients. So we actually stood up this very intentional call function within our GI team. So we were proactively calling patients that were showing out of care, and we were encouraging them. So if we got a no the first time, or if we weren't able to get in touch with them, oftentimes that's where they would have just kind of fallen off the radar. But this process kept them on the radar. And if they expressed a concern about a colonoscopy in particular, we stood up tools around how our folks were supposed to have conversations with them. We had to answer some pricing questions, which is a very complicated answer to provide depending on their insurance and that sort of thing. We started to realize that some patients that were fluent in Spanish were receiving materials to their homes in English, so we were able to clean up some of our processes around that. But we also unearthed some of the cultural taboos that we were seeing uniquely among Hispanic males. We were able to engage some of our teammates and community members from the Hispanic community to really advise and guide us on what were the right levers to press in terms of addressing patients' concerns around this. And then in addition to the strategy that we had through the GI team, we had a separate strategy through primary care. So if a patient said, I'm just not comfortable with a colonoscopy, or I can't afford to do that right now, we had other pathways to be able to encourage fit testing. We had a whole initiative launched through our primary care teams, and we even went so far as to assessing and identifying non-attributed patients to making sure that we were able to get them attributed so that they could have a follow-up and be encouraged to have their colorectal cancer screening. So that was our journey that we went on. And there were lots of those kinds of projects that now that we had this really great data, we're able to be lifted off across the system. And more recently, a lot of that bench strength was able to be deployed into the greatest pandemic of our lifetimes, at least. And so, I'll touch on a few things that I'm really proud of, but there's a ton more that Atrium Health stood up throughout the pandemic that I think speak to our commitment around health equity, but also speak to how we had built previous muscle that we were then able to flex throughout the pandemic. And specifically in the very, very early days of the pandemic, right when it started to come in, the first cases were showing up in North Carolina, we were already ready to go. We were looking at the cases by race and ethnicity. We had those tools stood up, and we immediately caught that we were seeing a very slight disparity among our African American patients, but more concerningly, most of the tests that were being done for African Americans in those early days were actually in our EDs, which means that they were already sick and symptomatic and coming into the ED. So we knew that we had to rapidly address some gaps in COVID testing access. And as we listened to community members, we stood up a big multidisciplinary team. It was the COVID Health Equity Task Force. It had all kinds of folks from across the system. It had data scientists, biostatisticians, epidemiologists, quality professionals, community relations and community health professionals. It had physicians and nurses and other providers on the front lines of clinical care. I could go on and on. But what I will tell you is that task force, which met sometimes multiple times a week in the early days, was the breeding ground for what became our nationally recognized roving COVID testing model. So that's where we were using GIS mapping to assess where the patterns were of COVID cases, and then making sure that we were bringing those tests to the communities that needed them most and that may be experiencing the greatest gaps in testing. And within a couple of weeks of having stood up this solution, we were able to close the gap in testing for both African American and Hispanic communities. But furthermore, as we continued this over time, we were actually able to over-test in vulnerable communities. And a lot of this happened by integrating our community relationships into this very data-driven scientific conversation, so that we had a partnership with an organization called Village Heartbeat Inc., which is close to 70 African American churches that are across the greater Charlotte region that were able to work with us because we needed to prevent our testing sites from being overrun. We actually needed to do very concentrated, kind of laser focused marketing in those sites. And so we were able to work and say, okay, we're going to market this among a few congregations, or we're going to market this among Village Heartbeat Inc. churches. And so that's how we were able to really reach critical masses of African American community members. We had similar partnerships in the Hispanic community with similar results. I think more importantly, though, that established the trust in the early days that we were able to build on to do other things, such as our Million Mask Initiative. Our CEO, Gene Woods, committed very early on to a public-private partnership that allowed us to, we initially had planned to distribute 1 million masks, but by the time it was all said and done, we've distributed over 3 million masks, and we prioritized, we used our data, we used our GIS mapping, and we used our community relationships to distribute over 3 million masks in underserved communities. And the trust that we built through that process allowed us to then stand up, once vaccinations were available, our community immunity for all strategy, which was really around vaccinating underserved communities, running right at vaccine hesitancy and concerns and cultural myths that we were hearing were forming in certain communities. And we continue to work on that to this day. We actually have now a vaccine equity task force that met daily, starting in January. We shifted it to a few times a week. Now we're still meeting often weekly or every other week, just to make sure that we're on the path to continue to bring vaccinations to the most underserved communities. But we were working through those trusted voices in the community, such as church leaders, community leaders, things like that, to be able to bring, to make sure it wasn't just the big health system that was advocating that you get vaccinated, but it was actually your pastor or a community leader that you really looked up to and respected, and they'd already gotten their vaccination. So that work continues to this day. And we've been recognized for some of our efforts. CMS recognized us in 2020 for some of the work that we've done around colorectal cancer screening, as well as our demographic data wall. And then we were very honored and privileged last year to receive the Carolyn Boone Lewis Equity of Care Award from the AHA. And it's while on one hand it's a privilege to receive these awards, I think for many of us that were doing this work, I think we still felt like it wasn't enough. And so as you think about what's happened over the course of the last year and a half, especially following, seeing all the disparities that played out across the country around COVID-19, but also post George Floyd, I think a lot of questions were emerging among our leadership and among our board around how can we lean in even more deeply into our for all part of our mission. What are we leaving on the table in the way of impact that we can start to now use our size and our skill to impact? And there were some big challenges that we were, thinking about. We were hearing about not just the immediate devastating impacts of COVID-19, but also some of the fallout around social determinants of health. We had baked in some of these into our COVID testing and vaccination sites. We were screening folks for social determinants at our sites. But the question is, what was happening more broadly in the community, and how could we leverage our size and scale to start to impact that? We were seeing disparities in unemployment, disparities in housing access. And so that led us to start to think about how we can think about health equity holistically, because and this is, no surprise to this group, traditionally when healthcare systems define and think about health equity, what they're really thinking about is equity in clinical quality and outcomes. And let me be clear, there is a ton of work for all of us to do around equity and quality and outcomes. It's enough to keep every one of us who's joined this conference, if we devoted the rest of our careers to working on that alone, it still wouldn't be enough. But that alone, I will submit to you today, is not sufficient enough to solve for health inequities that play out in our community. And we've got to be able to move outside of our areas of direct control and into those domains of influence, because we all know that 20% of health outcomes are controlled by healthcare systems, right? Or healthcare providers, I should say. The other 80% is what's happening outside of the healthcare system and what's happening out in communities, and these deeper, entrenched historical inequities that have compounded themselves over time and generations. And so that's what led us to this framework. And as we started to iterate, we started to develop what we called our social impact strategy. And it resided around what we called our 4 pillars of health equity. Because I just felt like if we're only talking about equity and clinical quality and outcomes, we've got to start to tackle the other pieces of what drives health inequity. We've got to have some really honest conversations about access to care. Because what we saw during COVID is there were all these patients that were out in the community that were uninsured, that didn't have those traditional healthcare pathways established, that were very vulnerable to being misnavigated through the healthcare system because they didn't have primary care providers, they didn't have insurance, and they desperately needed basic healthcare access. And so those were the honest kind of soul-searching conversations that we needed to have, is how do we better facilitate access to basic healthcare, preventative and primary care services in our communities? How do we double down and grow all of the work that we've started around health equity and clinical quality and outcomes? But the last two legs or pillars, if you will, of our 4 pillars had to do with having a bigger conversation around social determinants of health. And we made the choice to bifurcate that conversation about social determinants to really call out that acute social needs piece. So if I'm a physician and I'm in front of a patient and the patient, I feel like I've sufficiently addressed all of their healthcare concerns, but if they say, I don't have any food in my pantry when I go home tonight, or I'm about to be evicted in 2 days, I don't have the money for the rent, I don't know what I'm going to do, and I don't have anywhere to go. That is a crisis. That is an immediate, acute crisis that we will all agree for that patient, for that family, is going to immediately impact their health and could in time have long-term implications on their health status. And it could put them at risk. That toxic stress that comes from housing instability, food instability, that can, over the course of our lifetimes, we know, create higher risk of chronic disease. And in children, we know all of the research around ACEs and how that really can put children in particular on a different trajectory for long-term health consequences associated with that toxic stress that they experience in childhood. So that is something that we've got to be prepared to deal with. And so that's why we called out the work around acute social needs. I'll talk to you more about that in a minute. And then really said, okay, we can't control all these social determinants of health as a health system, but we need to try. And we need to leverage our size, our political influence, our voices in lawmaking bodies, our community partnerships in a new and different way to start to expect more from our communities to catch folks before they slip through the cracks. And so that was the work that we set out to do through our social impact strategy. So I'll unpack each of these for you and how we're thinking about them. And then I'd love to take questions at the end. So, in the past, we've put all of our efforts into our brick and mortar clinics and hope that patients make their way to them. But if they don't make their way to them, then, that's the challenge for the patient, right? But in the future, that's not enough. And we learned that so well during COVID. And I'm very proud of the hospital at home that our team stood up, where we were able to care for patients who were COVID positive in the comfort of their homes. And they were actually able to keep patients out of the hospital, which for a lot of other reasons operationally was very important when you think about a COVID surge and managing against that. But oh, by the way, this is where patients would greatly prefer to receive their care. And so the hospital at home really showed us the promise of what in-home care could do for future work and inform future work around health inequities prevention. We also saw how virtual care became this critical pathway. Oftentimes, I think virtual care and the conversations, that we're still activating on, and I'm sure many of your organizations are really lobbying for payment parity around virtual care. So we're very engaged in that work right now. But one of the things that our team has had discussions about recently is making sure that we inform lawmakers and other folks who are making the decisions about virtual care that this can be a critical tool to help us eliminate disparities in access. So we have what we call community-based clinics that are prioritized around serving disproportionate numbers of uninsured and patients on Medicaid. And I will tell you that we saw a 20% reduction in no-show visits thanks to virtual care. And when I say virtual, I don't just mean video visits, I mean phone visits with their providers. We saw a 20% reduction through COVID thanks to access to virtual care. So we know that that's a way of the future. And it makes perfect sense, right? You don't have to organize healthcare. You don't have to schlep your children on 2 or 3 bus stops just to get to the clinic for something that you really just need to talk to the provider about, and maybe we could have medication sent to your home. So those are the problem solving that we need to start to get behind as it relates to access to healthcare. We also saw the promise of mobile care, being able to take our mobile units out into every single community that needed us, it made us incredibly nimble. And, I called, my husband would make fun of me. I called our GIS maps, our COVID GIS and vaccine maps. My second child, I have one daughter, but I called these maps my second children because I just loved them and I would look at them all the time. And what it would allow us to do, though, is we could see at any given time, you know what, we were really focused on this community and that community needed us for this past month, but now this community over here needs us for next month, and we better get down there. And who are our partners in that community? Which churches do we need to be talking to? Community centers do we need to be talking to so that we can bring the care where it's needed? And we were able to get folks out to those care sites because we have the trust and the relationships of the community leaders in those communities. But we believe that this is a winning strategy, not just for COVID testing and vaccinations. We think it's a winning strategy for greater healthcare access in general. And we are building out healthcare models to meet that need through mobile units. In addition, we still think brick and mortar matters, and we think we're doing analyses across all of our markets around, are we in all the right communities, particularly those underserved communities that may not have historically had brick and mortar in their communities? And if not, what's the right solution to stand up? What services need to go into those areas? So that's the work that we're engaging in now around access. It's a four-pronged approach, and we've got to get all of them right to think holistically about access. So what you're going to see is just an illustration, and I feel the need to say this because this is not the current goal setting, but when we thought about what's the promise around having high quality data flowing in, because again, we still have to get that equity and quality of care and outcomes right. We cannot neglect that piece. So we got to get that right. That's where we started, and we've got to stay on that journey. But what's that piece, and how could it look in the future? So this is a future state envisioning. So if we were to say that we want to reduce disparity and mortality overall for African Americans, then how do we leverage our scale, our geography, our different service lines and markets and territories to be able to get the biggest impact around disparities reduction? And so this is what I worked on with one of our fantastic chief medical officer leaders who is really helping us think through for our board so that our board can envision what a future state would look like. And we still think we can get here. I'll show you in a second where we are now, but really, could we have every region and market firing on all cylinders as it relates to that disparities reduction? So translating that global disparity goal into local work, but also each service line, if you dive deep into their respective literature, and I've studied health disparities literature for a very long time, as many of you have as well, every service line has health disparities literature. And what is the prevailing theme, patterns, issues of concern, greatest good that can be done around a goal that's relevant to that particular service line institute's work? And so that's the future that we are iterating toward. I will share with you where we are now. For now, we've set up goals by region because Atrium Health Wake Forest Baptist came on board, basically close to a year ago. We were able to go ahead and get all of the regions moving in different directions based on disparities that they had identified in their respective regions. And we were very okay with the fact that we would have different goals in different regions. So if you look at the greater Charlotte region, for example, we've done some work already around the diabetes composite, and we had seen great impacts and equity around some of the things that more the transactional work that we can control. Are we screening consistently for the screening elements within the diabetes composite? But when you looked at the outcomes elements of the composite, so A1C control, blood pressure control, that's where we were still struggling. And so we've built some special health equity dashboards just for this work, and that's happened in all of the markets. North Central and Western NC, which is Atrium Health Wake Forest Baptist, they focused on early cancer screening and early early intervention around that, and also safety events. In our Macon, Georgia facilities, they've really focused on congestive heart failure. That's been a big focus of theirs, and also heart failure mortality. So we like the fact that we've had different goals this year. The other thing that's not on this slide, but I think is important to call out, is we're starting to align around looking at our data in the same way. So it's really hard, when different health systems come together, we're all on different platforms. We're all measuring things, but we might be measuring them in different ways. We might have different reporting mechanisms. The data over here doesn't talk to the data over here, and it's not mapped or integrated in the same way. So that's all of the wonkiness that comes when you integrate different players into a single health system. But what I will tell you is that's okay. We know that that's a part of it. So our chief medical officer has actually been organizing all of these conversations around, okay, are we doing risk-adjusted measures or not? Those are all the conversations that are happening so that we can all agree on common methodologies for how we measure and report the data. And then what can we all agree matters? There's different issues in different regions, and so we don't want to take away the local translation, but we do want to start to standardize how we look at the data and how we agree upon the measures that we're going to look at from a health equity standpoint. So that's the work that we're going through now. So I mentioned earlier calling out about acute social needs. So we have invested for a few years now in a tool that we call our Community Resource Hub. That is powered by Aunt Bertha. There is many vendors in the social care marketplace, if you will. It's just like electronic medical records vendors. And what I will tell you is I often call our Community Resource Hub this beautiful Rolls Royce that sits in our garage and that we don't drive around nearly enough. It's an electronic, living, breathing Rolodex of social care resources by community that we can then direct our patients to. And the reason why this matters is we need to be able to take away any hesitation that a provider may have to ask the question, Mrs. Jones, do you have enough food in your pantry? Mrs. Jones, any concern about your housing? Those are the kinds of questions that we've gotten tons of feedback from providers that they're uncomfortable asking if they don't have an immediate solution to intervene for their patients. We've heard that, for depression screenings. I don't want to do a depression screening on my patient if I don't have a resource to support them if they are having a mental health issue. I want to make sure that I'm providing good care. And so we have to put those tools in our providers' hands, and we have to make it easy. I don't think we're completely there yet, but that's the big rocks that our team is pushing uphill in the next year. One is embedding that into the EMR, but also thinking about clinical workflows. A lot of our early thinking is around trigger questions that are simple, doesn't take a lot of provider time. And then if that trigger question flags yes, then you would go into a full social determinants, acute social needs screen. But also really mounting up and rounding out our community health worker team so that when patients do get referred to social care resources, that we've got folks that are navigating them through use of those resources, making sure that they're landing well, and a ton of work that we continue to do with our community-based organizations to make sure that they're good catchers, if you will. So if we refer a patient to, say, a food security resource, making sure that we've got closed loop referrals. We do have many of our community-based organizations that are allowing for electronic referrals, but that's the work ahead. We want to build that out more robustly, and we want to standardize this work across the system. So that's the work ahead for us, so that we're screening the vast majority of our patients on a consistent basis and catching these issues when they surface in the clinical setting. Now, I'll talk you through the last piece of our strategy, which is around those root cause social determinants of health that over the arc of someone's lifetime could really determine their life expectancy. We had to make some decisions because we used a phrase in the early days of the creation of our social impact strategy that we were watering 1,000 flowers, and we are supporting a ton of different things in the community, and all of them are noble. All of them have everything that we were supporting had fantastic missions that any of us, if we heard it, could all get behind. But the net result of all of those 1,000 flowers that we were watering was that none of them were growing particularly well, or only a few of them were. And that we needed to start to focus and prioritize and get really crisp and clear on what were those imperatives that were most closely linked to the health and health outcomes of our patients, and how could we leverage all of our size, scale, political weight in service to those. So the first place we started was actually to look at our community health needs assessments. We looked at assessments that had been done in North Carolina and Georgia, because those were our markets, and we looked at the rankings, right? And we said, okay, what's the top 5? Let's focus and prioritize. And so you can see in the red boxes there, overall, that's what fell out as the top 5. But then when you look at them and you say, oh my goodness, how are we ever going to touch this? Poverty, uninsurance in a non-Medicaid expansion state, housing instability, food access. I mean, these are big structural problems that involve tons of players, you know, from the government on down to be able to influence them. How could we possibly make a dent? But I think the questions came up with some answers, is that we do have some power and we need to leverage that power. And so we started to map what are our levers of influence and impact that we can use. So most health systems are the largest employers, or one of the largest employers. So our lever is, you know, one of the largest employers in North Carolina is a huge lever. So thinking about ourselves, not just as the largest healthcare provider, but I believe the top 2 employers in the state. And so how can we leverage our role and how we employ folks to start to drive at the root cause of some of these concerns? We have dabbled in and are getting much more serious about investing in affordable housing in unique and creative ways. I'll tell you about that in a minute. And also understanding that we need to play a role in the food ecosystems in our communities, because when they break, when they are inadequate, our patients feel it and we see it in our clinical spaces every day. And so that's how we landed on these priority areas of food security, affordable housing, and employment. And I do want to emphasize, when I say employment, I don't just mean any old job, right? What I mean is a job that provides health insurance, right? Health insurance. In a non-Medicaid expansion state, our voices have to be really, we're always going to expand, you know, advocate for expanding Medicaid, but we really want to drive that expectation that to be a good employer is to provide health insurance, because there's, you know, only 3 ways that folks are going to get in the American society. There's only a handful of ways that folks can get health insurance: through their employer, through Medicaid, or through Medicare. And then a handful of folks get, comparatively speaking, their insurance through the exchanges on the individual market. So the employer provided piece is something that I just think we need to start to advocate on, in addition to Medicaid expansion. And family sustaining income, recognizing that that's different for every family based on what that family has going on, but working to role model that in our role as an employer, and also advocate that for that more broadly in our community. And then career and economic mobility. And we have learned a lot and focused on this through our work. So I'll tell you some of the things. We have stood up our Career Development Center. That Career Development Center is prioritized around focusing on students from underserved communities. For example, the Rise to Success program focuses on students who come from Title I high schools, getting them on a healthcare career path. They get their CNAs through this program, and they also get hired as employees. And many of those Rise to Success students actually became some some of our very first COVID testers and then vaccinators. And so that we've just got wonderful stories around that. But Education That Works is a program that's for our employees. And so we've done a variety of different programs in the employment space. We have made some very creative investments in affordable housing. We committed $10 million. Those are actually, one that I'm really proud of is Hill Rock Estates, which is, we provided a low interest loan to Roof Above, which is a homelessness services provider in our community. And Roof Above was able to buy and preserve what we call naturally occurring affordable housing. So this is an apartment complex where the rent rates were already below, or 30 to 80% of area median income. And so we were able to help preserve that affordable housing in our community. In addition, we were able to secure 50 units for our own teammates. Meanwhile, Roof Above was able to secure 75 units in that housing complex for folks that were permanent supportive housing for folks that were graduating out of homelessness. There's a ton of work that we continue to do around food security, and we're committed to doing that for the long haul. I will tell you, we've stood up our signature Kids Eat Free program, which is summer feeding programs to really augment what the school systems provide around free lunches during the year. And we focused on communities where there were gaps in those summer feeding programs. But more broadly, we're looking at food ecosystems. How can we start to look at the systemic issues around gaps in food ecosystems and solve for that, in addition to doing the programs like Kids Eat Free, which we're very proud of. So I'll close, I'll wind down with the last few slides. This is our social impact strategy blueprint. It's just simply a recap of everything that I've talked to you about. Our leaders are learning this like the back of their hands. We talk about it in all kinds of meetings. It all is structured around our 4 pillars of health equity: access, quality and outcomes, acute social needs, and social determinants of health. And it rests on the notion that everything that we do has to be awake to the influences that systemic racism can have on our work. Systemic racism is baked into the sauce of most large structures, institutions, systems. And so everything that we do has to be aware of that and guard against that in our design, so that we are not unwittingly replicating systemic racism in our solutions. And the big bold goal around this is that we're going to reduce life expectancy gaps in our most underserved communities, not by 2040, not by 2050, by 2030. So that really means we've got about 8 years to get this done, and that means that we have to move, very aggressively on our path. So that's the bold goal. It says 10 years, actually a little less at this point, but we are moving steadily, and we focused our first year on teammates, and I'm really proud of that. I don't have time today to go into a ton of detail, but we've stood up things like our Teammate Help Now program, which is really around helping teammates who have acute social needs and connecting them rapidly with ease to social services from some of our community-based organization partners. I'll close out with this. In thinking about our global power and influence as an organization, we've decided that we need to step into it fully. It's not just about being the largest healthcare provider in a community. It's not just about being the largest employer, or, we're very proud that we're educators. It's not just about infusing that into all of our academic programs and medical schools and residency programs. It's not enough to just be an anchor of the community, that we've got to round that out with the rest of our power. So looking at our policy and advocacy portfolio, we always showed up to the certificate of need parties. We always showed up to the Medicaid expansion parties. We've always shown up to the virtual care reimbursement parties. We haven't always shown up to the food parties, if you will, in state legislatures. We haven't always weighed in on a particular bill moving through the state legislature around affordable housing, because that wasn't technically in our domain, but we think it should be. And so actually our team has developed a very robust health equity and social impact advocacy platform that our government relations team is activating on. And we work with our community-based organizations to make sure that that platform is right and relevant, and that we're moving on the right things, and that our voices are showing up in the right way. We're architecting new and different types of partnerships than we've ever done in the past. We don't believe that we need to lead on everything. In fact, there's a lot of humility for us around this, that we need to follow the wisdom of communities, that we learned that way before COVID, got it reaffirmed to us during COVID. We have to listen and follow the lead of our communities. But we need to build partnerships that are different than they've been in the past, where it has been more about, buying tables at dinner and sponsoring. That we need to really think about what's the impact that we're having through our foundation work and grants that we make, but also grants that we write. How do we strategically funnel volunteers to the right causes? Because our teammates love to serve the community. And then how do we build out a portfolio of research around this, so that we're studying the impacts that we're making through this work? And that's actually some of the work that I love to jump in on, is how are we researching this, and how are we tracking the data? Because if we intervene here, what's the impact over here? Not just from a healthcare utilization standpoint or a bottom line standpoint, but we should study that too. But also what's happening in our patients' lives as a result of all of these social interventions. We can drive our social impact strategy through our sponsorships and investments too. And I think we're getting better and better at that over time. But I think new work for us is around driving that through our supply chain. So if you think about it, when a healthcare system sets out to save money, they outsource a service. Well, if that outsourced company then lowers the wages of the workers, doesn't provide health insurance, doesn't provide a family sustaining income, did we actually make our community better? Did we actually just shoot ourselves in the foot? So those are the really honest conversations that we're having with ourselves, and we're mounting up a ton of data and analytics work to be able to understand the impacts of our effort in the future. So I will close by saying how grateful I am for the invitation, and how exciting this work has been for us to build, and also just an acknowledgement that we're just getting started and we have a ton more work to do. But really appreciate everyone's time, and happy to take any questions.
Okay, thank you, Dr. Coltman. That was a great presentation. I'll just say thank you for the perfect balance between challenge and encouragement. I think we're all very challenged by what you had to say, but can all be encouraged that we can get started and tackle some of these issues. And the other thing, just as a physician, I'm really happy that you acknowledged and called out the work you're doing to provide resources to clinicians. It's my belief that we all want to be able to address some of these questions, but I can relate to the reluctance to ask a question that you won't be able to address. So it's really encouraging to see that you're going to be able to put some of those resources to your providers who I, again, firmly believe want to do this work. I do have a couple of questions in the time we have left here, so let me throw those over your way. So what tools, practices that you implemented during COVID, such as the roving mobile units, the equity task force, do you continue to plan to continue to implement and sustain post-COVID?
Well, I think, in some of this work, I will say not all this work was led by me or my team. I mean, there's just tons of people that have, stood up so many creative things. I think we all recognized that we were onto something magical with hospital at home, and just being able to send community paramedics out to do breathing treatments and, that kind of work. I think we're doubling down on that. We know that we need to keep that, because those patients would otherwise have occupied an observation bed in one of our hospitals. So we also have to be thinking about it's a reduced cost of care, better patient experience of care, and just a really creative solution that we were able to stand up. I think the other keeper is mobile units. I think we've loved how nimble we have been able to be through our mobile care strategies, and we think that there's promise in being able to bring care in a very nimble way to wherever it's needed. And then I think, the health equity analytics work, we certainly didn't start that during COVID. I think we've learned a lot about how we can use it in real time, very aggressively. I mean, some of our GIS maps, we were able to overlay COVID cases. You do this with anything. We've done this with chronic diseases and overlay that with and incorporate data from the CDC Social Vulnerability Index so that we can see the relative disparity in the most vulnerable, underserved communities. And when you marry those two together, it allows you to be really precise about where your interventions can be. And so I think that kind of grassroots, real-time data analytics work is something that I think is here to stay for us.
Yes, and that actually a perfect segue into the other question, which you could go on for a while, but what other use cases do you see for GIS mapping?
Oh, I could talk for days for GIS mapping. I mean, I think there's just so much that we can do around. It's informing where we place clinics now. It's informing, I think, where we could start to see different types of community health programs and interventions. But I think it could also inform where we see low healthcare utilization, where we really realize, gosh, what's going on in these communities that they're not engaged with the healthcare system, and what do we need to learn about those communities that may bridge those gaps. I mean, in my mind, the possibilities are endless about what you can do with GIS maps, and that's why the GIS map leader at our health system is one of my BFFs as a result of that.
Okay, great. Well, thank you again so much for your time today and a wonderful presentation.
Thanks for having me. Really enjoyed it.